My name is Lauren Williams. I'm Adult Services Manager for the Columbia Public Library, which is part of the Daniel Boone Regional Library System. Welcome to today's Lunch and Learn. Thanks for braving the stormy weather to be here with us. May is Mental Health Awareness Month, so we'll be hearing about resources in our community to serve those in crisis. And today's Lunch and Learn is co-hosted by the library, the League of Women Voters of Columbia, Boone County, and the Children's Grove. So like I said, we've got people here in the room and on Zoom. So if you'd like to ask a question during the Q&A portion of the event, we are going to save those questions till the end. Go ahead and put those in the chat if you're on Zoom. And if you would use the drop-down menu to select everyone so that everyone can see the questions you're asking, we would appreciate that. And then in the room, we'll be walking around with the microphone so that people on Zoom can hear the questions being asked in the room. We are recording this presentation, so it will be available in the next day or two on both the League's YouTube channel and the library's YouTube channel for future viewing. And now I'd like to welcome Marie Scala of the League of Women Voters, Columbia, Boone County, to say a few words and introduce our speaker.
Thank you, Lauren. I just want to thank Barbara Hoppy for chairing the Lunch and Learn Committee and being responsible for the programs that we've had this year. I want to thank the library for wonderful collaborative process in putting these on. And I want to thank Children's Grove for co-sponsoring this particular one. This will be our last Lunch and Learn until September. So we'll have a little hiatus over the summer. My pleasure to introduce Carissa Kessler, who's Director of Crisis Services in the Central Region with Borough Behavioral Health. She helped with the rollout of 988 in Missouri in July 2022, and I know that was quite a stressful process, very almost sudden process. She oversees multiple crisis programs within Borough Behavioral Health. She earned her Master's of Education in Counseling from Stevens College here in Columbia. And during her 17 years in community mental health care, she's provided case management, suicide awareness and prevention trainings, debriefings, and other crisis intervention services to members of the agency and the community. So we're very lucky to have her here today to talk about the current system for responding to behavioral health crises. Okay.
Thank you. Thank you all for having me. It's a pleasure. I'm hopeful today we can talk about the different crisis services in our community. And of course, at the end, I'll leave time for questions if anybody has any additional information that they would like. Sorry, did not unmute. Okay. So first we will start by talking about 988 in Missouri. And I will give you a little bit of history on how that number came about. Technical difficulties, thank you. There we go. Okay, now, there we go. Okay. So 988, if anybody is not familiar, you might have heard of the 10-digit suicide prevention lifeline number that has existed for many years. In July of 22, that number shifted to 988. And if you will see, it was also renamed the Suicide and Crisis Lifeline. And so what that means is we know that crisis is self-defined, and we wanted to make sure that people understood the number wasn't only utilized if you were suicidal, right? It could be used if you were experiencing any sort of crisis. So the history that we show, 2018, the National Suicide Hotline Improvement Act was created. 2020, the FCC designated that 988 would be the 3-digit number. And then you can see how that all worked out. And then in July of 22, we officially rolled out the lifeline number and transitioned to 988. So I kind of covered this a little bit. Since 911 is classified as an emergency number, they are able to use the geolocation on that. Right now, 988 is we're not able to use the geolocation when someone contacts 988. So the important piece to look at is on that last line. When somebody does call 988 right now, It is routed to a certified answering center based on that caller's area code and prefix. And so I'll talk a little bit more in a few slides on kind of what that process looks like. So we kind of use, 911 is your medical emergencies. 988 is your suicide and mental health crisis number. So kind of easier to remember a 3-digit number than a 10-digit number, right? So the purpose of 988, we are connecting individuals in crisis with a mental health professional. The crisis line is available 24 hours a day, 7 days a week, which really gives easy, rapid access via call. And we also have the ability to chat and text. So if you are more comfortable in a chat conversation or a text conversation with a crisis specialist, you are able to use those features as well. So utilizing 988, we are seeing a reduction in the healthcare spending with more cost-effective early intervention. And it has shown to reduce the use of law enforcement, other public health, and other safety resources because, a lot of times people would call 911 when it was something that a crisis specialist, a mental health crisis specialist is able to resolve. So here's the crisis continuum, as we call it. And this is kind of the national continuum, but then also something that Missouri is adopting and following, of course, as well as, at work. So someone to talk to, right? We have covered that, our 988 suicide and crisis lifeline. And then we have someone to respond. So 988 is our front door into accessing some other services. So someone to respond is our mobile crisis team. So this is a pair of crisis staff, and we'll get into a little bit more in just a second. So they're responding on scene. The point of this team is diversion. So we are able to dispatch this team to a location and prevent usually law enforcement or some other emergency response from having to respond. And then we have somewhere to go, which is our behavioral health crisis centers. Okay, so why 988? I kind of covered this already a little bit. An easy 3-digit number to remember, gives individuals rapid access to behavioral health crisis care and support. It is the front door for engaging individuals in a mental health crisis, connecting them to care. We're able to reduce a lot of the utilization of other, law enforcement and other emergency response services. And it also provides that care in what we call a least restrictive environment. So whether that be, at their home or any other community location, they're able to utilize, like I said, phone, chat, and text. So our mobile response, so someone to respond. This is a multidisciplinary team that will provide a safe, compassionate crisis intervention. And when I mentioned in the beginning, crisis is self-defined. And so they are going to look at what are the needs of that individual and provide the appropriate follow-up based on their needs. It is on site, whether that be in their home or another place in the community. We've in fact responded here to the library to an individual that was in a crisis. And so our team was able to meet with that individual, help identify the crisis, resolve that crisis, which prevented, from law enforcement or any other sort of emergency system in responding. So we talk about diversion, removing them from sometimes those often inappropriate systems, right? So the hospital, our goal is not to get them to the hospital. We're trying to resolve the crisis before we get there, or even the jails. So now we move on to the third piece of the continuum, our behavioral health crisis centers. I do have some flyers and additional brochures that I can leave here for distribution if anybody would like to take them. Our BCCs, they provide a drop-off for our law enforcement. So the individuals who are in a crisis, maybe they don't need to go to the hospital, they don't need to go to jail. Our law enforcement officers can take them to a behavioral health crisis center to get their needs met. And really, and it's a walk-in, so anybody can present to the behavioral health crisis center. I say anybody, it is individuals 18 and up. Right now, we do not serve minors, but any individual 18 and up. Again, it's shown to have a cost savings due to redirecting that individual, being able to provide the services in that least restrictive environment that will meet their needs. So we triage, we assess, we stabilize, and then we provide the immediate resources necessary to that individual in crisis. Our BCCs are open 24 hours a day, 7 days a week, 365 days a year. It is a place where an individual can stay up to 23 hours. Now, as soon as an individual walks in the door, we are immediately assessing, trying to stabilize and address their crisis. And let them stay as long as necessary to get stabilized and safety planned, or, you know, a safety plan in place. But there is the option to stay up to that 23 hours. There are a variety of services that are offered at our behavioral health crisis center. There is psychiatric medication available. There is peer support available. If you're not familiar with peer support, that is an individual who has the lived experience. So they have had a mental health or a behavioral health crisis, maybe some substance use, they've experienced homelessness. So they can honestly say, I know what it's like to be in your shoes. I've been there. And then they use their recovery history to help guide that person through their own, you know, recovery crisis de-escalation. There's therapy services that are also available. And then hopefully we're utilizing our services to link them to ongoing care. Sometimes that is not the case, and that's okay. But there are no boundaries on who utilizes our behavioral health crisis. Anybody that is experiencing what they deem a crisis is able to walk in and receive those services. Those services are not required. You know, I mentioned several different types of services. It's not required that you receive all of them, but those are the ones that are available. Okay, so the next piece that I think is important to talk about is what happens when someone calls 988. So we might give them the information, here's the suicide and crisis lifeline, but I think it's also important to be able to tell them, and this is what will happen when you call 988. So an individual calls, they're going to hear that greeting. There are some options if they would like a more specialized call center, and so they can press 1 to get to a veteran lifeline. They can press 2 if they would like a Spanish speaking lifeline. Press 3 if you would like LGBTQIA+ individual, that lifeline. Or if you are, you know, you just want the standard English, then you can wait past that greeting and you will be connected to a certified call center. So there might be a brief hold while that individual is transferred to the call center based on their selected preference. Again, it's based on area code and prefix. And so what does that mean? You are here in Columbia and you recently relocated from Georgia, and you still have that Georgia phone number. So you are here in Columbia, but you dial 988 and you will be connected to a call center in Georgia. You will get that immediate crisis specialist. Being a certified call center through this lifeline gives every call center access to the call centers where that person, their area code and prefix is coming from. Does that make sense? I'm just looking at the people in there. Okay. So we will attempt to resolve that crisis on the phone. If that individual would prefer to speak to somebody in Georgia, then we have that contact information. We will make that form transfer, which means we're going to contact that call center. We're going to let that crisis specialist know who is on the phone, what we have done already, and then transfer that call to that crisis specialist. So that's a little bit different than just a cold transfer, right? Where we're just dialing the number and hanging up. This is a warm transfer. where we will be, making sure that the receiving crisis specialist knows who's on the phone, what they've identified their crisis, and then they can take over. We have staff at Burl who does follow-up to individuals who have contacted our crisis line. So within a next business day, that individual is gonna get a follow-up phone call. We know she called our hotline. Did you get everything that you needed? Is there any additional information that we can provide or any additional assistance that we can offer? Okay, I skipped ahead and maybe got a little bit out of line here. So once the call is answered, they're gonna reach that counselor. The call is considered answered when, we pick up. Now, the call is completed when obviously we hang up. We do track the number of calls that come into our center, the number of calls that we are able to receive, and then we also, are able to see our abandoned calls. What does that mean? An abandoned call is when somebody calls 988 that hangs up before the crisis counselor is able to answer the call. So oftentimes we catch those and we will try to call that number back. Sometimes we reach the individual, it might be a dropped call, maybe their phone died, maybe they're in a place where they don't have service. So here is kind of the Missouri model. We do have 7 certified answering centers in the state of Missouri that will accept calls, the texts, the chats, and then provide the follow-up. 6 of those centers answer 988 calls. And we have 1 center that does the texts and chats, and it is actually located here in Columbia, if you're familiar with Deaf Lead. They answer all the texts and chats for the state of Missouri. So each of Missouri's 150 counties, including the city of St. Louis, are covered by one of the centers in the state of Missouri. And then on the next slide, I'll kind of show you the routing structure, but we do have a backup center in Missouri as well. So if by chance one of those centers is not able to take the call, then we have a backup center that will capture all of it. So here is the routing structure. You can see those 6 kind of gray, lighter purple. Those are the 6 answering centers in the state of Missouri. So behavioral health, Response, Burl, ComCare, Compass, Ozark Center, and Providence. So Providence will serve as Missouri's backup center. If, for whatever reason, Providence is not able to take that call, then it is routed to a national backup network as well. So here is Missouri's call data, and this is July 22 to July 23. I have some more current numbers available as well, but since the launch, Missouri has continued to be one of those top in the top 10 states when looking at the 988 data. So in that year, we took almost 57,000 calls to 988. And the average answer speed at that time was 18 seconds. It's a lot.
It is.
It is. But I think it speaks to ease of accessibility, 988, versus a 10-digit number. I think it speaks to the level of services and the level of care that our crisis specialists are providing. And I think it now with being able to add chat and text, we're seeing a lot of younger individuals utilize the service as well, because they're more comfortable, chatting or texting with someone. Which is great, because it really allowed us to widen that net of individuals that are utilizing the crisis. So here are some more current, and I just did February and March. April numbers are not out yet, but in Missouri, in the month of February, we answered almost 6,300 calls. Missouri had a 93% answer rate of those calls. So 7%, right, were abandoned calls, whether that is, like I said, not able to be answered before the crisis counselor connected. And then the average speed in February to answer the call was 15 seconds from the time that person dialed 988. So March, you can see the numbers went up to almost 7,000 calls in the month of March. Again, the 93% answer rate and the average speed to answer dropped down to 14 seconds. Okay, and then here's Burl's 988 numbers for the same months. So with our center, we answer a couple of different crisis lines. We don't just answer 988. We have other hotline numbers that also ring to our facility. So total, in the month of February, we answered 1,881. We had 1,881 inbound calls in the month of February to our facility. 668 of them came through 988. So we are able to differentiate what number individuals call to get to our center. We have a 96% answer rate with an average speed to answer of 9 seconds. And then in March, you can see our numbers went up a little bit. So almost 2027 total inbound calls, with 672 of them coming through 988, 94% answer rate, same average speed to answer of 9 seconds. So that's kind of where we are now. Yeah. And I'll say, the staffing part of this was hard. This was new to us, adding 988. And so trying to figure out the staffing patterns, we wanted to add just the right amount of crisis counselors, but not too many, but then not enough. And so it's taken us, a year or two, because it's 24/7. So do you staff more people during the day? Do you staff more people overnight? And just making sure that we're utilizing the workforce that we have appropriately, keeping them busy. We also have certified peers located within our call center. So oftentimes we'll see individuals who call and, we've been able to de-escalate the crisis, but they still need some additional support. And so we can transfer those calls to our certified peer specialist, who can then take, talk to that person a little bit more, maybe help them identify some additional resources or needs that they might have. So this slide does give you a QR code. Just gives you the 988 information. There is 988lifeline.org if the individual is wanting to chat. Otherwise, you can just call or text 988 and be immediately connected with a sort of a crisis specialist. Okay, and the last piece, my part, is the contact information. If you have any additional questions, or tomorrow you're thinking about, oh, I meant to ask that, I wanted more information on that piece, you're welcome to send me an email, and I will be happy to either, follow up with you by phone or email, or however you prefer to be contacted. And then the last part, if you do want more information about 988, this is the Department of Mental Health website that goes over all of that information as well. I know, I'll leave it up there for a second. Here, I'll go back. I will leave it up there if anybody would like to scan it. These codes are becoming quite popular. Everything's got a QR code. Okay, so that is everything I have. I'm happy to take questions. If anybody has anything they would like to ask.
We've got several questions online, so we'll start a couple of those and then move to in room if that's okay.
Yeah.
Someone asked, can someone who is with the person in crisis call 988?
Yes, good question. We call that a third-party caller. And what we will do, of course, the crisis specialist is going to answer the phone, allow the person to, I'm here with a friend, right? Here's what's happening. I'm not sure what to do. Can you provide some additional resources, information, or support? The crisis specialist, of course, will offer that caller some information or some assistance. They would also like to speak to the individual in crisis as well. If that's not an option, then of course the crisis specialist is going to guide that caller through the different options and try to give them the information that will resolve the crisis with the least restrictive outcome. They might say, here's a resource, here's an option, here's what you should do, here's what I recommend.
The first slide includes drug issues. What situations might be part of that?
First slide, can I go back? Where we were talking about 988. I'm not sure. I'm going to guess that maybe it's related to a mental health crisis or substance use. So what we will do, and that is we're addressing all the reasons why someone might call. And so if we think they are, they might be under the influence or they're currently using substances, then we're going to make sure we provide resources and supports, but also try to guide that individual to get the services that they need. We do often have to call for EMS if we believe that individual is unsafe and we're not able to help safety plan, or maybe there's not anyone available to help them. Then at times we have had to call EMS. We try to get the information to get them to respond to that location. If that doesn't answer the question, let me know, but I think that.
I have two related to police, so I'm going to put them together.
Okay.
One is, why are people with mental health issues still being taken to jail in Boone County? Who makes that decision? The other one is, have you provided this information in a training format to Columbia Police Department?
Yes. So the two questions, when we talk about least restrictive environment, of course, we're trying to divert those individuals from going to the jail. If there is a legal piece involved in why we have responded or why law enforcement is there, then, jail has to be the answer if there's a safety or a legal piece. When we talk about providing information to the police departments, yes. And we actually have another crisis program that has community behavioral health liaisons who work directly with law enforcement and the courts. So there is a community behavioral health liaison assigned to each law enforcement agency within our 10-county coverage area. They provide referrals and information to law enforcement. They are aware of 988. They are aware of the behavioral crisis centers. And so we are in and out. We're in the shift meetings. We're, letting them know what 988 is and how they can contact their community behavioral health liaison for that referral and follow-up information as well.
This one is, you'll have to help me out. Maybe you will understand it.
Okay.
If the individual is deaf or HOH,
Hard of hearing.
Hard of hearing.
okay, are you able to provide an interpreter in the mobile crisis response?
So for the deaf and hard of hearing, that we would connect with deaf, who provides that follow-up information for the individuals who are hard of hearing. When we encounter them in the field, or when they maybe have a caller, we also have access to another interpreting services for individuals who might speak a different language. And so we have working relationships with all of those agencies to make sure the needs of all of the information or all of the individuals who access 988 are getting their needs met.
And I believe you've answered this, but the question was, when was BHCC implemented?
So when was the Behavioral Health Crisis Center opened? I don't have the exact date, but I know when we first started, we had to be open 8 to 5 because of staffing. There are certain positions that we are required to have in place in order to operate a behavioral health crisis center. We are now 24/7, and I believe that went 24/7 in September of last year.
I've been doing a good job for years, but I've been noticing that when I used to
Can you?
work, when Turning Point's first door opened, but where everybody trying to reach everybody with mental health. Now, Turning Point is a change. Y'all not working with the people that's up there running Turning Point. Because the people get kicked out for no reason, can't take a shower. I don't know why so many people getting kicked out of there, but I really do talk to them. Now, I'm kicked out. Yes,
Yeah.
I'm kicked out. I'm questioning this man. What can we do about that when this man is causing so many problems? And the workers up there sell crack cocaine. I can prove this. So what's being done? That's why they have mental issues. My friend killed her. Cause she couldn't come up there and take a shower. She really would. I couldn't believe it. What's being done with y'all working with these other people like Turning Point? Y'all don't see what's going on up there. It gotta be something. I don't know why I can't see talk to the people that work up there. So many overdose. The cops being called up there. Police cases diseases up there. Taking a shower. It was not like that on our watch.
Yeah.
I know a lot of you guys working up there. Staying, see that plays a lot with our mental health.
Sure. Well, first, I want to say I'm sorry about your friend. I know that is tough. And so I'm sorry that that happened to you. To the point of working with the different community agencies, you know, we do a lot of collaboration to the best that we can, and that's community-wide.
You do.
There is a homeless outreach team that does exist within our community, and so,
I understand you do not try to forget about it,
yeah.
but still try
Mhm.
to
Yeah,
Yeah.
and a lot of it has to do with the want. And so trying to connect, excuse me, connect with the individuals, try to identify. Trying to identify their needs, and sometimes it takes time to get what they need met.
But I'm not trying to tell you that sometimes the people that's running it won't tell you the people. They working up for money. I'm telling you the truth. They won't tell you this. I'm trying to tell you what I'm going through. Never did nothing trying for, but I can't take a shower. Never. People say I do. Women get kicked out of places for no reason, and they homeless. They hurt. They get raped on the streets. And men do too.
Can't hear. The people on Zoom can't hear. She needs a microphone. Maybe we can talk afterwards. Is that okay? Yeah, we'll talk afterwards. Good.
I'm sorry if you've already answered these, but sometimes my mind wanders when I'm thinking about other things in mental health. So, if someone were to call because 911 is embedded in our memory, does 911 divert to 988? If they determine it's mental health and not a health emergency?
Yeah.
Okay.
So we're actually working on that a little bit more, and that is part of the state movement as well, is to really work on embedding 988 more within 911. And so there's a lot of pieces to that. I know we're trying to work on that relationship a little bit more, make that process a little bit easier through education and helping them identify when it's appropriate, but it's hard. Because there, you know, there may be some intended or some perceived liability to that. And so how do we work through all of those pieces to make sure we're getting individuals where they need to be? So the short answer to your question is yes, we're working on that education and the collaboration. Yeah.
Just for my clarification, I have an 817 area code. So it sends me back to Texas. If I were to call 988, does it route me to Texas and then Texas is responsible for routing me back to a local, or do they try to resolve it? And then if they can't be resolved in Texas and then back to local,
Yeah.
is that how that would work?
So you would be automatically routed to Texas right now. Their crisis specialist is going to work with you to resolve whatever is going on. If they feel like you need to come back to the area where you are, you know, maybe physically located, then they have access to a resource center where that can happen, you know, seamlessly, and we would transfer them back.
And maybe last, maybe not last.
It's okay.
So you mentioned, the crisis teams. What would be the composition of one of those teams?
Sure, good question. Okay, and I'm sorry if I did leave that out. So we have a crisis specialist. And then the second person of that team is a certified peer specialist. And so they're responding in pairs to that location, whether that be home, another place in the community. We do implement like a safety screening to make sure that it is a safe response for our team. Does that person on the phone even want somebody to come? Because if they don't, we're not gonna go. But you know, we also assess for environmental safety. Are there guns? Are there animals? And are you willing to secure your animals? And if not, then, you know, maybe meet me down the street. And so are there other individuals in the house? And are they aware that we're coming? So there's several questions that we go through to make sure it's an appropriate and safe response. But yes, that's the pair, a crisis specialist and a certified peer.
Okay, when you mentioned that Missouri is in the top 10, I don't know if that's a good thing or a bad thing, but is that on sheer call volume or is that per our population here in Missouri? I mean, is it, what kind of number is that?
That's going to be volume, and then they also look at answer rate. And so, you know, here's our volume, how quickly are we answering the calls?
I guess I didn't ask that, right?
Okay.
So that 57,000 number or thereabouts,
Mhm.
in California with, you know, 10 times the population, that may be a small number, but so when you talk about call volume, that is just an absolute number of calls,
Mhm.
regardless
Yes.
of what the population.
Yep, that is the total number of calls that are coming into the center. So within our 6 centers in Missouri, that is how many calls came into the states combined.
Okay,
Yeah.
and I promise one last question.
No, you're, those are all good questions.
So on your speed to answer, I just want to make sure, does that mean, because it sounds like you have a menu driven voicemail answer so that you can direct it appropriately.
Mhm.
So is the speed to answer how quickly you're actually talking to a
Mhm.
human that you've been redirected? Okay.
Yep, it's from the time someone calls 988 to the time they are speaking to someone on the other end of the phone.
9 seconds, that's great.
To follow that up. I think you should be a model for the nation on customer service. If you can answer the phone with a live.
Why we want
Just, I'll just ask a quick question, then I'm going back and forth. So this is coming top down from federal funded, is this fully funded by the federal government and people get insurance?
So no insurance is required. Somebody's paying for it, but if you call 988, if you walk into our behavioral health crisis center, you will not get a bill. There are several different levels of funding from, yes, federal down to some state funding as well. But the crisis services within our state are free
Wonderful.
to the individual. Right? These covered.
Somebody.
But you will not get a bill if you utilize one of our crisis.
And you said within 23 hours. You use that,
So someone can stay at our behavioral crisis for up to 23 hours. Once you hit 24, it becomes a different level of care. And that's not something that our current behavioral health crisis center is set up to provide. I don't have offhand the average number of hours someone is staying right now, but I think we're usually in kind of like the 3, 4, 5 hour range. Once someone comes in, we're doing that assessment, doing the triage, and that stabilization starts. And there's a couple of different, we have kind of a living room model where there's some chairs. There's also some couches if somebody would want a little bit more privacy. We have some more private rooms. But really, we're trying to get individuals assessed and then get them in front of the services that we provide as quickly as possible.
Thank you for doing this program. I had a couple questions, follow up on the state issue. So basically, is this number something that is in all of the states? Okay, so it is in all the states.
Mhm.
And then the other question that I had is, say if you don't live in this, let's say you don't live in this state, you have to be visiting, but you have a family member that may need the service, are you able to tap into the local here? I think somebody asked that in regards
Like a third party caller, like can you call
Yes.
on behalf of someone? Yeah, absolutely. We are going to take the information from the caller and try to get as much from them as possible. And then the next question is going to be, can we speak to the individual in crisis and try to help them as well? Oftentimes that's not possible. They don't want to talk to the crisis worker. So then we are going to work with that caller on, here are some options. Here's what we would recommend. If they're not willing to, just kind of talking them through all of the things. If they're not willing to do this, we could do this. Sometimes the last, the answer is you do need to call law enforcement for some additional assistance. If they happen to be unsafe or, suicidal and they're not willing to go someplace on their own, then we do sometimes have to call in law enforcement to assist with that transport. But through these different crisis components, we really try to not have that be the last, the option. A lot of people think when they call the hotline, we're gonna automatically send them to the hospital. Like, that is not that's not our goal. That is not what we want to do. Now, at the end, if that's what we have to do to keep everybody safe, that's what we have to do. That goes back to that least restrictive environment. How do we resolve the crisis in the least restrictive, environment?
And my,
Yeah.
my final one is, so if you did call, because I just happen to be here from out of state.
Yeah.
You would just say, I'm calling, and then you just explain, do you seem like you're pretty networked with all the other states you operate and all that?
Yeah, so when you became a certified answering center through 988, there's a very robust resource center. And so we had, like, for Burl, in order to be a certified answering center, we had to go through a lot. To your point, it was a lot, but is it absolutely worth it? 100%. But there's a lot that you have to do in order to be a certified answering center, which gives you access to the National Resource Center as well.
Thank you.
So-
I'm gonna try to make sure we have a program number.
Sure.
Online question, we'll come back to the audience.
There are several. Somebody is still trying to grasp the financial aspect. And the question is it funded federal, state, local, or private?
So the financial piece for the individual who is accessing services.
Well, we're talking
There-
about the whole 988.
Right. So individual will not be charged. The funding levels there's some federal funding, there is some state funding, and depending on where the services are, there could be some local funding.
And then we still have some concerns about the connection between you and your staff and the police. So I'm gonna put a couple of things together.
Okay.
You said you were doing the training. Are your crisis staff currently corresponding with police to suicide calls or co-responding? And then another question related to that is 911 seems to immediately dispatch, so it would have to be a quick assessment of the need to direct it to 988. So how, you see what those two questions are getting at?
Yes. So related to 911, there's protocol that they have to follow when someone calls 911. What centers are working on is how do you follow that protocol quickly to determine if it's a 988 transfer. And that's individual by the dispatch centers. Some are a little bit more willing than others to make that transfer. And so locally here, we are working on that. We are trying to get more embedded in our dispatch center. Repeat the first part of that.
About co-responding.
Co-responders. So there's several different levels of programs that work with law enforcement. Right now, our community does not have a co-responder program, but that's where we utilize those community behavioral health liaisons to work with law enforcement and the courts. So ideally, when a law enforcement officer responds to an individual in the community who is experiencing a crisis, maybe isn't connected to services, they are going to be in contact with that CDHL, who will then do the follow-up with that person. If it's an immediate safety risk, then that's gonna look a little bit different. But then they can also, call 988 if they wanted to, if they felt that it was appropriate, but if it's an immediate risk. So for our mobile response team, that's someone to respond. If it's like an active suicide, that's what we consider emergency response versus diversion from law enforcement. Does that answer the question a little bit?
So this one will be enlightening for all of us. What do you think needs to happen to reduce incidents of suicide by police?
Beyond the bounds of this.
No, I think there's always room for education and information and making sure that our officers know what resources are available to them. And what they can access, how do they access it? I guess that's gonna be my short answer. I don't know if it answers the question, but I think there are a lot of services maybe that exist for that population, and we just, need to do a better job or more education and letting them know what exists and how to access it.
I have a couple questions. What's the address of the crisis center here?
So I have a card, yes, I have cards that everybody can have, but our behavioral health crisis center is on East Walnut Street, right behind Stevens Lake Park. So we have our adult specialized services, and then our behavioral health crisis center is there as well. So if you turn on Walnut Street off of Old 63, right there behind Stevens Lake, it's up on the hill.
Also, you said only individuals 18 or older would go to the crisis center. What if you have someone younger?
So we're still going to address what is going on with that individual. We're going to try to get their guardian involved. The other piece with that is it's self-report as far as demographic information. The only thing that we capture with 100% certainty is a phone number. But we're still going to address it over the phone. If, a youth calls, we will try to get the guardian involved or anybody else who might be in that location. Occasionally, pretty rare, if we feel like it's an immediate urgent situation, we've worked with, our, law enforcement to ping a phone number to try and find out where that individual is physically. Doesn't happen very often, but we do have the ability to do that if we feel like it's a kiddo in emergent need.
Also just a comment, even though your answer time is quick, for someone in crisis, that could be too long. So in that kind of situation, probably another individual if possible. If one is there, calling in for that person. But that would be a long time for some.
Could be, yeah, you're right. No, you're absolutely right. And I try to look at the progress that we've made, since it started going from 15 and 16, down to 9.
Yeah.
But yes, you are right. You are right.
Going through the menu,
Yeah. So with that, if they just want to go, you can press 0 right off the bat. You don't have to push all of those options. You can wait through it, or you can push 0. Let me go back to that slide here.
So does the menu tell you that right at the beginning?
I think it might go through that and then just say, or press 0, or you can just wait through all of that. Yeah. Yeah.
I had a bunch of drugs, terrific, so I'm sorry to you for
Thank
the
you.
service you provide. I'm kind of a data oriented person, so I'm wondering if you're giving to additional types of data you might be collecting. For example, it would be good to track over time the different types of calls you're getting, suicide, drug overdose.
Yes,
Do you collect that kind of data?
we collect more data than I can wrap my head around. But yes, and because of how we operate and who we operate, you know, under the state, they require a lot of different data. So we capture ages. So we have it broke down, is this 0 to 8, 9 to 15, like what's the age of the caller? We capture military status. We capture, oh, there's a full drop down if we can work with that individual to identify like what is their primary concern. And so we're looking at, is it medication? Is it homelessness? Is it access to services? Is it suicidal? Is it acute mental health? And there's definitions that go with all of that. So there's a full contact sheet that we have to fill out. Now, sometimes we don't get that for every single call because it is self-reported. And so they might not want to give their name. And so that's okay. They can remain anonymous. We're still going to ask the same questions and try to identify as much as possible. But we do have people that don't want to give their address. They don't want to give their name, even though it's confidential. The calls are not recorded. They still don't like to give that information. Likely because they think we're going to send the police or send them to the hospital.
Yeah, I'm thinking also about data the person who's receiving the call would be taking. They would be making some assessment about the nature of the call and what category it fits into.
Yeah,
And then you also talked about, you have certain results that you're trying to focus on when you deal with the call. Have you thought about a way to gauge whether you're realizing the desirable results you're trying to get? In other words, if you wanted to gauge over time, are we getting better at delivering results? You have to collect some type of data that gauge the quality of the solution you came to.
so are you thinking, to make sure I understand your question, like we were able to successfully resolve 98% of the calls, and 2% we had to refer to law enforcement? Is that kind of what you're thinking?
Yeah,
Something like
something
that?
along those lines. I mean, if you're managing a process like this,
Mhm,
you want to, I think, know whether you're getting better
mhm.
at responding to incoming callers in an effective way.
Yeah,
And that would
Yep.
suggest you need some type of data to know how you're doing it.
right. And so part of what every month we look at, what were the primary concerns when somebody called? We're able to, based on what that crisis specialist determined, 50% of them were acute mental health crisis. 5% were related to homelessness, because we track the total number of calls that we received. And then we can go through and look at what was the primary concern and then what was the disposition or outcome. And so we do have that information. When somebody calls, we're immediately assessing for suicidality. So one of the first questions that we are going to ask is, are you suicidal? And if they say yes, likely that next question is going to be, have you already done anything? And if that answer is yes, then that turns into more of a rescue, like we need to get somebody to them versus, okay, now we can go, and address the need of the call. So there's a lot of information that we capture, both internally, some of it we have to report externally. The contact sheet, we run reports and look at what we're able to capture. I think we have a great staff. Sure. Thank you for the question.
My question is back to the process that takes place when a call comes in. Well, not even necessarily when a call comes in, but one of the slides showed that the police would have the option of bringing people to the crisis center
Mhm.
rather than taking them to jail or to hospital. And my question is just simply, what kind of training, that seems like a heavy duty decision to make on the part of a police officer, and I just wanted to know what kind of training or preparation they have to prepare them to decide in a given.
Right,
case. Yeah.
right. So we're working with them in the different trainings and the different, ways to get in front of them to let them know about the BCC and what that means. You know, as far as the pretty, there's not a lot of barriers to accessing our PCC. Obviously, if they're responding and it's a medical emergency, you know, we're gonna ask that they not bring them to the BCC. Or if there was a crime being committed, then likely that's not going to be a BCC drop off. But if an officer comes with an individual who they think is appropriate, we don't expect them to stay. They can bring the individual and leave, which makes it nice because they don't have to do, you know, we like as much information that you can give us, we will take it. But we also have a lot of people just walk in and know nothing about the situation that they were in or nothing that, you know, that has happened. So we try to make it pretty low barrier for, law enforcement to drop an individual off. So it's just continuing the education, making sure they know we're here, here's what we do, and here's how you can utilize the service. Does that answer your question?
It sounds like they have an incentive to use it. They don't have to. do it.
Because they don't have to stay and they can get back on the streets to, you know, to do what they need to do. So yeah, that falls into that cost effective, you know, less utilization of our emergency response system. Oh, 2 minutes.
We are right about the end of our, just wanted to say thank you so much. This was fantastic. Obviously, by the number of questions, you can see that this is a really important issue and people are thrilled about the service. So, yeah, and I know that we really are glad that it exists for sure. As we said, this will be recorded and posted on YouTube. So please share it so that people can get this really valuable information. We'll keep a lot of information on hand here at the library for people to pick up as well. We've got some upcoming events with the League of Women Voters. We have a series of called Before You Vote about misinformation, disinformation, your digital hygiene, learning about AI and its impact on elections. We've got flyers here. I also put a link in the chat to that series. And then we've also got a workshop at the end of June on the 29th on a Saturday about getting out the vote, what you can do as an individual or in groups to get people to turn out to the polls. So please join us for those. And thanks everyone for attending. We appreciate it. And thank you.
Yes, thank you.